Okay. Oh, okay. It's taking 11:01. So everybody was so happy to welcome Professor Kerstin Ritter with a background of mathematics. Dr. Kerstin is a professor for computation neuroscience in Department of Surgery and Psychotherapy at Charité en BCCN. Also, she is leading her lab in deep learning of neuroimaging-based diseases decoding. Today, Professor Kerstin will talk to us about next level medical imaging analysis. Dear Kerstin, the screen is yours.
Hi everyone, thank you Sava for this nice introduction, and also thank you to Julian for inviting me. So my name is Kerstin Ritter and I'm going to talk about next level medical imaging analysis. And I would like to start with a short motivation here. So as you know, reading radiological images is a highly sophisticated task requiring advanced education and a lot of experience. And usually those tasks are performed by well-trained radiologists or neurologists. But a number of studies have shown that those diagnoses made by medical experts strongly depend on individual characteristics of the medical experts, such as age, experience, or perceptual abilities. And the question is, can computer programs be better in solving some of those tasks? And the hope is that those computer programs are not only more objective, but also more sensitive in identifying subtle disease alterations. And in my talk, I'm going to talk about different computer programs from machine learning to deep learning. I will shortly talk about promises, and then I will mainly focus on some challenges and also how to solve them. So the first important question is, how does a computer learn? I think you all are very familiar with this. But so artificial intelligence, machine or deep learning is a part of artificial intelligence, and artificial intelligence has mostly been about rule-based learning. So this means you define a set of rules, give the rules to a computer, and then the computer sticks to the rules in order to come to a certain decision. Machine learning and deep learning is different because this is learning without being explicitly programmed. So here the computer learns based on examples. And the main difference between machine learning and deep learning is that we have in standard machine learning an extra step of feature extraction, where human experts think about features that best describe the input data, and then a relatively simple classification algorithm can be used. So for MRI data, an example is to use the hippocampal volume, which is known to be important for Alzheimer's disease, and this is a feature you can extract, and then you can use a support vector machine or something else on the hippocampal volume. Deep learning, in contrast, is different because this allows end-to-end learning, including representation learning. So here the representation of the input data is directly learned within the model. And this is actually one of the main reasons why those algorithms are so successful these days. How does machine learning work in disease classification? So usually we have at least a training and a test phase. In the training phase, we have a number of subjects who are characterized by different kinds of data, such as clinical data, neuropsychological data, blood data, and imaging data. And we have a corresponding set of labels, which are here the diagnosis, but can also be symptom severity or treatment outcome. Then a machine learning algorithm is used to learn a mathematical relationship between those data or extracted features on the one hand and the labels, which are here the diagnosis on the other hand. And this learned relationship can then be used to predict the label for totally new, unseen test subjects. And there are a number of different models one can use to learn a mathematical relationship, and I would like to focus here on one particular kind of deep learning network, namely convolutional neural networks. So these are deep learning networks optimized for processing arrays, such as images or videos. So they are perfect for analyzing medical imaging data. They consist of different types of layers, convolution, pooling, and nonlinearity. And the basic idea is that little filters are learned, which are slided over an image in order to extract certain characteristics of the image. So, and the special thing about CNNs is that you get a hierarchical representation. So in the first step, you might get image intensities, then edges might be detected, then more complex objects such as eyes or nose, and in the end, whole faces can be recognized using CNNs. Those CNNs have led to state-of-the-art results in many medical imaging application tasks, including lesion segmentation, prostate segmentation, identifying cancer on different kinds of images. And those CNNs have also shown to reach or even exceed human level performance in a number of different tasks. CNNs have also been used in neuroimaging. So here the input are mostly structural MRI data, and then those filters are guided over the structural MRI data in order to look for certain characteristics. Most studies so far have focused on Alzheimer's disease. One reason for this is that you have in Alzheimer's disease quite clear pathology. So you have atrophy in the brain, which is visible in the MRI there, although it's difficult to distinguish between Alzheimer's related atrophy and just only age-related atrophy. And the other reason why mostly Alzheimer's disease data is used is that there's an open database called ADNI, where all researchers can access to, and this really boosts the number of machine learning studies also using CNNs. But there are also some other studies in schizophrenia, also depression, substance abuse, and some studies are showing that you get a better performance using CNNs, and others it's more comparable also with standard machine learning analysis. So it's not clear how much you profit from using CNNs in neuroimaging data so far. Just to give you an impression how the MRI correlates of disease can look like. So I just had the example with Alzheimer's disease. So here you see an MRI image of a healthy control and of a patient with Alzheimer's disease. And as you can see, for the patient with Alzheimer's disease, you have enlarged ventricles, hippocampal atrophy, and also cortical atrophy. Another example is multiple sclerosis. So here you have an image of a healthy control and of a patient with multiple sclerosis. So this is a different sequence. This is a FLAIR MRI sequence. And MS is characterized by those lesions here, which can be seen as white blobs. But it's very important to keep in mind that those lesions are not specific for MS, but also healthy controls can have lesions, especially elderly people or smokers. And even more difficult is to define MRI correlates of psychiatric diseases. So there are a number of studies showing, for example, that there's also reduction in hippocampal volume and also some other kinds of biomarkers, but it's much more difficult as for neurological diseases. So the promises of machine learning and CNNs in medical imaging analysis is, of course, that we have the idea that there is so much data and that there must be something important in there to detect. And especially a promise is seen in personalized medicine. So we have a very diverse patient population, and we would like to stratify our patient population in order to get a targeted approach. And machine and deep learning here has shown to be able to perform a task that usually requires human perception and judgment, has led to state-of-the-art results in medical imaging recognition tasks, and therefore provides a huge potential for reducing diagnostic errors. But there are also a number of challenges. The first one is small sample sizes. So we don't have millions of images to train our networks on as Google, for instance, has, but usually we have much less. So usually we have a couple of hundreds or even a few thousands of images. So here you see a number of open databases. So the largest one is UK Biobank, which at the moment provides data of 40,000 subjects, which is huge and which is really nice, but it's a cohort study. So the people are between 50 and 70 and are mostly healthy, and you don't usually have a lot of cases per disease. And in addition to UK Biobank, there exist a number of disease-specific databases, for example, the ADNI database for Alzheimer's disease, or the PPMI database on Parkinson's disease. And yeah, and then there are, of course, also private databases. So, for example, we we use mostly open databases, but we also try to cooperate within Charité to get access to private data sets, but they are usually much less, but often more clinically interesting. There are different ways how to deal with small sample sizes. So one is data augmentation. So this means that you shift and transform your data in different ways in order to enlarge your database. This is also a form of regularization. So this makes your model more robust. And another very successful approach is transfer learning. So this means that you have one data set on which you train your model, and that you then transfer the model, knowledge from this model to another model on another data set. So for example, you have a large data set one, train some model, and then you transfer the knowledge from this model to another model for a data set which you are interested in and which is usually much smaller. And how does the knowledge transfer work? So usually you transfer the weights from one model to the other, and then you can initialize the new model with those weights, or you can also fix the weights of some of those layers. And this has been shown to work quite well even across domains. And we applied this in neuroimaging data. So we wanted to classify between MS patients and healthy controls. And we had a rather small cohort here. Therefore, we pre-trained our network on ADNI data. And using a CNN with no pre-training, we got an accuracy of 71%. And using pre-training, we got a considerable performance boost to 87%, which you can see here, which is comparable to a standard classical machine learning analysis just using the T2 lesion load together with a support vector machine. So you get a similar accuracy, but a lower sensitivity and a slightly less AUC. But what's interesting here is that, of course, we know that the lesion load is important, and therefore it's okay that we get this accuracy, but we can get this a similar accuracy using CNNs, which are completely naive about these lesions. And I'm also coming later to this, how to visualize what has been important for a CNN. But here I just wanted to show that also the heat maps, so which are explaining what has been important for the final classification decision, are much more concise when we pre-trained the data. So this really helps. But these are only like initial studies. It's not yet clear how to best perform transfer learning. So how different can the training and the test data be? So for example, we have the UK Biobank data where we have an age range of 50 to 70, and then we want to detect some disease in people between 20 and 30, and it's not clear how similar the task and also the data has to be. And this is something we are going to investigate in the newly built CRC funder built by Ulf Leser from the Humboldt University. So this is the question, how to combine all those different databases we have and to increase the performance for specific tasks. The second challenge I'd like to discuss here, and I'm sure you already talked about this within this week, is the data quality. Of course, we assume or think that we need high quality data. So this means that it should be digitalized, standardized, interoperable, representative, safe, or usable. And this is usually summarized in those FAIR criteria: findable, accessible, interoperable, and reusable. And this seems to be easy to get, but in the medical fields, it's usually quite difficult. And just want to show you some examples. Of course, the reports we get by medical doctors are quite diverse. Then we have changing diagnostic guidelines. So for example, the McDonald criteria changed from 2010 to 2017. And as you can see, the diagnosis changed here. And we analyzed a data set where we mostly had those CIS patients. So these are patients with a clinically isolated syndrome. And there are no mostly MS patients. And of course, this also shapes our machine learning analysis. And we had to make this differently. Then the MRI data is quite different and depends, for example, on the field strength, but also on the MRI sequence and different parameters. And just to show you a short example, so we wanted to analyze some clinical routine data from Parkinson or atypical Parkinson patients here at Charité, and we took quite an effort to get all those data. So we need to download them, and we took them in the table, and you just see how diverse all the folder names here are, and then also the sequences. They were so different, so they were so diverse, the data, that we could not use them in the end. And this was really kind of tragic, because the clinical question would have been very interesting, and if we would acquire the data in the first place in a way so that we can later use them, this would be very helpful, not only for machine learning analysis, but also for all kind of statistical analysis. And solutions here are, of course, trying to standardize the data sets as most as possible, use the same sequences, same parameters. And of course, I know this is very difficult to achieve if you also work together with different clinics who have their certain protocols and they don't really want to change them. But if we want to analyze those data on a large scale and not only rely on open data sets, this is a very important step to do. And then I also can recommend using the BITS format to have all the data set in a very standardized format. This really simplifies your analysis later. The third challenge I like to address here is the so-called black box criticism of deep learning algorithms. So they have been criticized to be hard to understand, although the performance is usually quite good. And it's important to note here that it's not about some kind of secret magic here, because they are mostly deterministic. They have some stochastic components, but they're mostly deterministic, and we can also completely look into those networks. So we can look at each of the weights. But what we mean here, that it's quite difficult to make sense of all those weights from a human perspective. But there are a number of ways to deal with this, and this is a very active area of research and computer science. And I'd like to discuss here one way to deal with this, which is especially important for image data. And this is the generation of heat maps based on input data. And those heat maps give the relevance or the importance of each pixel or voxel for the final classification decision. So those heat maps can help us to understand what has been important for a certain classifier in the image. And this is also an important way to detect bias in the data. So for example, those horses have only been recognized by the classifier based on the emblem. And this is a problem of the training data, because in the training data, all those images of horses had an emblem at the bottom, and this has been recognized by the image. And we used those heat map approaches for explaining classification decisions in Alzheimer's disease. So the motivation here is we have an MR image of a patient, we feed this into a neural network structure, and then we get a probability of 89% that the subject might have Alzheimer's disease. And just based on this number, it's difficult to trust it, both from a perspective of a patient, but also the medical expert. But if you give an additional explanation in form of a heat map that this patient has been classified or has probably Alzheimer's disease because there are have been importance in the hippocampus areas, which we know is relevant for Alzheimer's disease, then this is a way to increase trust in those analyses. And we developed here a transparent deep learning framework. So in the first step, we trained a CNN model to discriminate between patients of Alzheimer's disease and healthy controls. We applied it then to test data. And in the second step, we produced heat maps for each subject in the test set. And we compared here different heat map methods. In this study, for instance, we compared guided propagation with Lyell-West relevance propagation. And what you see here is on the right, the average of the heat maps of Alzheimer patients for guided backpropagation and for healthy controls. And for what you see here is that there's almost no difference between those heat maps. So this guided backpropagation more shows you what has been generally learned by the network. So this is a kind of sensitivity analysis. And in contrast, layer-wise relevance propagation gives you a difference between Alzheimer patients and healthy controls. So you see evidence for Alzheimer patients in those maps, but not in the healthy controls. And this is exactly what you want. You want to understand why does the CNN think that this person might have Alzheimer's disease. And we also further analyzed this. I don't have the slide here, but we looked into the relevance in the different regions, and we found much more variability of the relevance in the Alzheimer patients for the healthy controls, and this was quite interesting for us. And we also think that those heat maps might be useful for trying to identify clusters in the data. So for example, different subtypes. But what's very important to note here is that with this, we don't completely understand what has been important for the CNN. So we can't really tell if this is atrophy or lesions or something else. We just know that these areas are important. And the next step would also be to understand what really has been important. And I'd like to show you the other example. I've just shown you the study before where we pre-trained our network on ETNI and then fine-tuned on MS data. And here we were interested if the CNN is really picking up the information of the MS lesions or is using something else. And what we found here, so here you have the heat map separately for several subjects, and you see that the network is really using those lesions. But what was interesting that it mostly used the lesions in posterior parts of the brain and not so much in frontal areas. And this was quite interesting, so that the CNNs does not only learn that lesions are important, but also the location of the lesions. And this can be partially explained by the true lesion distribution in the data, where you also see that the MS patients have proportionally more lesions in the posterior part. And the last challenge I'd like to address here is reproducibility. I think you all also already talked about this. So also machine learning studies are suffering from problems of reproducibility, and the reasons for this are usually small sample size together with a publication bias. So here you have the sample size on the x-axis and the accuracy of a y-axis, and you see a wide range of accuracies, especially for diseases such as ADHD or also depression, and you also see a trend to lower accuracies for larger data sets, and there are different explanations for this. Of course, this could be overfitting on the small sample sizes, but it could also be that those small sample sizes have less heterogeneous data, and therefore the learning problem is simpler. And then another problem is that the data is not representative, and so a famous example is face recognition, where it has been shown that those algorithms are much worse in identifying Black women than white men. And this is also a problem in medical applications where the training data sets are often biased. So this is true for genetic databases, for example, where most of the people are European people, and this is also true for neuroimaging databases where also most people are white Caucasians. And for example, for a famous skin cancer detection study has mostly been trained on images of white skin, which makes clinically sense because white people suffer more from skin cancer. But of course, it's then difficult to transfer this model to Black skin. And this is something which is very important to keep in mind and very useful. Here are so-called model cards where you put all the information and on what kind of data it has been trained and where to apply that. And we, for example, also looked for different accuracies between males and females in our machine learning algorithms. And we, for example, found that we usually get quite higher accuracies for females than for males. And we still need to understand this better. And then there's a high flexibility in data analysis with the pre-processing, how to extract features, how to do this feature selection, what kind of machine learning models, how to optimize the parameters. This is especially difficult for deep neural networks. You can, there are very many ways how to train those models, and I found this 10 years reproducibility challenge quite interesting. So would you dare to run the code from your past self? And I think you're quite brave if you would try. And the best way to deal to address this is to be very strict about splitting your data into training and test data. And there are different ways how to do this, like cross-validation, but it's usually very good to have a really held out data set which you do not touch in all your time, where you try to tweak your models and try different things out, because this then gives you a true estimate of the performance. And what I consider as a very good possibility are those machine learning challenges. So they are very common in computer science, but not so much yet in the medical field. So the first phase is for model development. So there are some training data with labels released, and teams from all over the world can take place and develop their models. And then in the second phase, they test their models on the test data without labels, and the team with the best model then wins. And this is really a way to benchmark your data, and I think this should be more and more done also for medical imaging data. And I just want to show you one example here. So we took part in the depression challenge, where we had access to data of almost 3,000 patients and healthy controls, and the task was to classify between patients with depressions and healthy controls. And we've got an accuracy of 64% here, and the best team had an accuracy of 65%. And this was very interesting because most of the people expected much higher accuracies, and we as well, because there are some studies showing that there are accuracies of 70 to 80% for detecting depression, usually in smaller sample sizes. And also the organizers did expect that, and we were trying and trying on the training data set, on the release data set. Like, we used very simple classifiers to very complex data sets. We used additional data sets. We used multitask learning, and we did not get a higher accuracy than 67% on the training data set. Yes?
Can I ask a question here? That's really interesting, I think, also for our work. But therefore I want to understand how exactly this worked. Did they hold out the data themselves and not give them to you, the test data?
Yes.
Oh, that's amazing. I think that makes a big difference, I guess.
Yes, this makes really a big difference, yes.
Because everyone is overfitting to the test set too.
Yes, yeah, absolutely. So because it's really hard if you have the data set, then really say, okay, we close that completely away. Yeah, and then, yeah, and what I also think was very good about this challenge is that not only you train your own models, but that a lot of people with very diverse approaches test your models, and then you can see really how good you get.
Yeah.
Yeah. Yeah, so we also took part in another challenge, which was about predicting fluid intelligence in children. So here we had a larger database of 8,000 images of children between 9 and 11 years old. So this was the ABCD challenge and also the ABCD cohort. And there are also, like, I think 23 teams took place, and then the mean squared error was reported. And also the conclusion from the challenge is that you can't be better than just predicting the mean of fluid intelligence. So that does not, that all those machine learning and whatever you want to apply to those images, that it does not help you to predict fluid intelligence. So this is a very challenging task. And I think
that's the best possible result.
Yeah, yes. Yes, absolutely. But it's always like, yeah, but I think it's really great to have this challenge. And there was a recent challenge where we did not place, but it was about predicting age based on MRI data, which can be more easily done, and which is also important for a lot of neurological disorders and also psychiatric disorders.
So how do the organizers make sure that the image quality is sufficient of the test set? Because I can imagine it would get very frustrated if you know the image quality, for example, is not representative in a test set when compared to the training set, and then you would get worse performance just because the test set is not representative.
Yeah. So I don't know exactly how they did this, but they usually use, like, they have the same imaging protocol, so this is the same data, so they have of course full access to all the data, and then they probably use a stratified approach to randomly sample data out of there, so that this has the same distribution. So for example, for the major depression, for this data set, we had in addition to those MR images, we had access to the age, sex, and the imaging side. And then of course the distribution and the training and also the test set should be the same also. So it does not make sense to have the training set on young people and the test set on old people. So this has to be ensured by the organizers. For the ABCD challenge, I think they used as a training set all the data, all the ABCD data which was currently available, and hold back the additional data set which they did not yet release. But of course, you don't have, so then you really have to ensure that there was not a scanner upgrade or something else. So you don't have, yeah.
Okay, great.
Yes. Okay, maybe we can further discuss this in a minute. I'm just going to conclude. So why is translation into clinical routine so difficult? And I think it's mainly about divergent concepts between machine learning and hospitals. So machine learning needs lots of data. They prefer standardized data. They love well-defined problems. They depend on the gold standard of labels. They're computationally expensive. They require methodological expertise and are perceived to be a black box. And hospitals, in contrast, project the data, which is very important. Have very heterogeneous data. They provide unstructured problems. They have changing diagnostic guidelines, and also the medical knowledge is accumulating. And also for example, new MRI sequences are used, or new diagnostic guidelines issue, and it's really difficult to adapt to this machine learning. So this is a less fixed problem that we usually have in computer vision. They often not yet have the right infrastructure, like for data management and computing, but there's a lot of movement at the moment, especially at Charité, and I hope that it's going to be easier and better in a few years. They compete with tech companies and hiring experts, and of course they require transparency and responsibility. And I think it's really important to work on merging those concepts closer, because if we have large, standardized and nice data sets and also good collaborations with clinicians, this will not only help those machine learning studies, but generally all kind of statistical analysis. And I think we could get many more interesting medical insights here. And with this, I would like to end my talk. I'd like to thank especially my great team, Claudia Schien, Fabian Eitel, Marc André Schulz, Roshan Rane, and Moritz Seiler. I'd also like to thank my collaborators and also the funding agency. And I'd like to thank you very much for your attention, and again for inviting me, and I'm open for questions now.
Yeah, thank you so much. That is a really relevant and interesting talk for our data week, I think, and I can imagine that, or at least I know at least one person who will definitely have some questions. I also have more questions with respect to the standardization and the point that you made regarding the different setting of a hospital and the machine learning community. So I could easily, you know, we're working with intracranial electrophysiology and predicting behavior from the patients. And we could easily think about also creating such a challenge. What I would find difficult is to choose only the data sets that have beautiful signal-to-noise ratio, because they do not reflect the average, right? It's a huge selection bias that also takes place, as far as I understood, for the challenges that you participated in. So it's not, it's in the end, I would say that the accuracy that is achieved there is not relevant for the patients because it's an artificial accuracy.
Yes. So.
Or how would you see a publication where I would write, we recorded, we scanned 40 patients and we excluded 10 of them because of bad image quality? I would say that is bad practice. I would say you need to include those with bad image quality because that's the reality.
Yeah, and I'm just trying to transfer this to the MRI data. So I think they also exclude people who have a bad scan where there's a large artifact or something, which I think is fine. What I think, which is, so the question is like the signal to noise ratio. So it really depends on also the task you're investigating. So for example, for the depression data, the question, so I think these are all like patients in a hospital, and they took the scan, and if the scan did not work or whatsoever, then of course they have to exclude them. But they did not exclude them because it might be difficult to detect depression on it. It's still a difficult task here, and I don't really know. I think I can consider that in your case it's much more difficult, and you have more variability between your patients, and it's also the question what you want to predict, if you want to do a prediction within a single subject or if you want to predict over a group of subjects. And for it, yes, both.
Yeah, both.
Yeah.
So
yeah, those. So I think the way would be to make it very specific. So if you're going to exclude certain subjects, then you have to say beforehand what your criteria are to exclude those subjects. I don't know how much it makes sense. It does not make sense to first analyze the data and then say, oh, we did not find what we wanted to see, and then exclude it. This is of course true. But how you can define beforehand, and I think for MRI data you can define beforehand. So if you have like parts of the MRI data are missing, then you have to exclude them, for instance. Yeah.
So my point maybe is more, I agree with you, yes, but still in the end, it makes the main difference between being a machine learning, you know, benchmark, where one can say in the end, yes, under optimal circumstances, this accuracy can be reached. And but then I would not agree with the notion that this could be clinically useful.
Yes.
Right, because it's a benchmarking, artificial benchmarking situation.
Yes.
And ultimately, at least we, and I think also you, would like to move to a time where we are actually creating something that is helpful. For patients.
Yeah, absolutely. And the main question is if we can get better data, or we have to stick with the data we have already in clinical routine. And I just can say for the data set we wanted to analyze within the atypical Parkinson, we wanted to make a differential diagnosis between different atypical Parkinson patients. So this was a really interesting question and nice to investigate. And here, and of course, this is then clinical data. There were a lot of Fremdimporte, so it was not all acquired in the hospital. But if we would have trained any machine learning model and did get anything out of it, we would not have known, is this trustworthy or not? So I think it's important to increase the standards and to have better data. And I think for MRI data, this is possible. to have like more standardized data, because people are doing this for those large cohorts, but usually in the clinics the extra effort is not taken to make those comparable images. For example,
I'm working in a clinical neuroradiology, and Christopher, who raised his hand, is also working in clinical neuroradiology. So we are hearing you, but of course we also have the clinical perspective there. So you might consider that.
Yeah, absolutely. Of course, it's more expensive and you don't need it. But if you want, so for example, I think it would be very interesting to have the same protocol for the Department of Neurology and the Department of Psychiatry, so that you can maybe do some analysis across like MS patients with depression or depression.
But that's the case.
That you can have like some.
We have that in Berlin. At Charité, it's all, the protocols are having the same sequence parameters between psychiatry and neurology. So,
so what I found from the Department of Psychiatry, I usually hear that they usually do not scan. I don't, but maybe we can discuss at some other point. But they usually also have another place where they usually get the images, and they usually also, so it depends if it's research data or clinical data.
Yeah, that's right. That's right. Christopher, you raised your hand.
Yes, well done. Hello, thanks.
Hi.
Great talk. So yeah, as Julian said, I'm working in the clinics as well in the radiology department, neuroradiology. And so my questions are somewhat similar to Julian's, and that is, or actually first a comment. So when you exclude patients based on artifacts, a lot of these exclusions are presumably because of movement artifacts, right? Because when you do an MP-RAGE scan and the person is moving, everything is blurred, so you cannot use it for your models, and so you exclude it. But if this enhanced movement in the scanner is not like normally just distributed across all patients, but has something to do with the underlying disease, then you're already adding a bias in by excluding this kind of data. So that's just a...
Yeah, absolutely. If you have, you mean if you have someone who has a tremor or something, or it's kind of...
Yeah,
right.
Movement disorder.
Yes,
I mean, that's the clinical reality, that the worse...
Movement disorder, yes.
The worse they are affected, the worse your data is going to be, the more you're going to exclude them.
But sorry, can I? So how do you deal with this? With your do you exclude any data with respect to movement disorder, or you just keep everything in, or what do you have? Do you have a
well,
strategy?
in the clinic, you work with whatever you've got.
Yeah.
And for research, I mean, maybe Julian can say something about how he handles it. So do you include everything for your analysis when you are...
I think it is a very important topic and a very difficult one. That's why it comes up here. So I think we kind of have a classification, a mental classification of what we perceive as usable or not. And it's absolutely not accurate, and it's not always objective. And I think it's a bias that we need to keep in mind. And if we come across better solutions, we should be open for them. But right now, I do not have a good answer, except that, of course, if the fMRI data are completely contaminated with movement artifacts, we're going to exclude the patient. But you are right, that was probably the most affected patient. In electrophysiology, we do control for specific symptoms, and that makes it easier. For example, I have focused my research on hypokinetic symptoms instead of hyperkinetic symptoms. So we usually exclude tremor patients, and we state that specifically that our research is about the loss of the ability to move and not about tremor and hyperkinesia. And that has made my life much easier, because in electrophysiology you also have cable movement artifacts that can look like actual brain signals, but are not But in the end, if we want to capture the entire spectrum of a patient's symptoms and also the entire spectrum of the disease severity of a disorder, then we will have to try and improve the data acquisition, as Kerstin has rightly said. Ultimately, we can. And for example, a colleague and friend from China has developed blow-up headcast for the MRI. I think that would already help a lot for movement disorders patients. So it's not, it fixes the head, but it's comfortable. And something like that could help.
We are already trying to do this by stuffing in a lot of pillows, right?
Yeah, exactly. So another thing that is known and done in the fMRI community is just fixing tape on the nose. So you're fixing the border of the scanner headcast with tape on the nose, and then the patient or the subject actually feels when he moves. And that apparently helps a lot already. I think there are measures to be taken, and one important point that Kerstin has made and that I agree a lot with is we should always try to acquire good data. Yeah. But in the end, we do not have a solution for how to deal with the bad data that we acquire, I guess.
My main question, which is a little bit different. So yesterday we had the talk by Stefan Klöppel about his apnea analysis with I think he used support vector machines. And he showed some interesting data that when you do the standard approach of comparing Alzheimer versus healthy controls, or maybe not so super healthy controls, but anyhow a control population, he got a classifier performance of something like 96%. And as soon as he included he used it on a population from his memory clinic. So pretty much the population, exactly the population you would want to use it clinically on. So if you develop an algorithm, you don't want to know, okay, is this person perfectly healthy or does he have Alzheimer's? You want to know, okay, this person obviously has some memory impairment or is somewhat strange. Does he have A, in general, some kind of neurodegenerative disease, and B, is it Alzheimer's, frontotemporal lobe dementia, or any other kind of dementia? So, I mean, the way more clinically applicable algorithm would be trained on the differential diagnosis and not on the healthy control. So do you know how to, or are there any plans to generally address this?
Yes, very important question. So the problem is, of course, we would like to train more models on differential diagnosis, but for example, the APNI database has just data of Alzheimer patients and healthy controls, and most databases for dementia have only those data. I was part of a project where the task was to discriminate between vascular dementia and Alzheimer's disease and mixed dementia. And for this, a cohort was acquired. So the plan was to acquire 350 subjects. And in the end, we had like 91 after 3 years. So it was much less. Therefore, we could, and therefore, we use standard machine learning approaches. So we extracted certain features from the MRI data, from the PET data, from the clinical data, neuropsychological data, and so on, and used a multimodal approach for classifying between them. And we found there that using multimodal data, we can achieve a quite good accuracy for separating those classes. But of course, we have, like, for the vascular dementia, there are more vascular effects on the MRI data, which we extracted as features. And for Alzheimer's disease, we had more atrophy measures, and this gave us quite a good separation. And with now, since we are using at the moment mostly those deep learning approaches, and I totally agree that it's at the moment basic science. So it's nothing we want to directly transfer to the clinics, and it's also not possible because we don't have the data set sizes so far. But if you have, for example, if you know, for example, Charité, that people are having those differential data from and different dementia cases would be very interesting for us to use this. And for, do you mean, like, was your question also to use a certain method, so how to approach this, like in a two-stage approach, like first trying if there's, yes, so this is also, so at the moment what we do, we really want to, we just use those CNNs and mostly on the imaging data and try to understand how they exactly work and if you get clinically useful information. So this is our approach at the moment. And of course, it's, if you want to bring this into clinic, it's very important to also include the clinical data and then also maybe to later have a two-stage process, first classify based just on the clinical data and then have to have different ways where to go. So for example, yeah, they have cognitive impairment and they have something else additional, and then you're going to in the imaging data, and then you have, for instance, different paths. But this only works if you have the data for this. And this is also the reason why we are trying to answer more simple questions, because we have the data for this. And a similar problem is for MS. The clinically more relevant question would be to try to predict at baseline how the disease evolves, if they gotta have a lot of relapses or they have a good disease course. And there, for example, we have access to a data set of Friedemann-Powell, which is not, I don't know if you know the CIS cohort, like 160 patients and trying to predict. And this is also maybe also coming back to the different data. So this is, I think this is relatively good data. So they acquired them, they also pre-processed them, and they have the tables, they have the clinical characterization. This is data we directly use as we get them, so we don't exclude any subjects there or so. We just trust the people who do the data acquisition, of course. And the other question now, which we also have, is can we also use the clinical routine data we acquire in MS? So they're like, Friedemann says, they're like maybe thousands of images probably. Yeah, so this would be in this direction. But yeah, so for the, and just one remark to the Klappe and the 96%, this is also, the ETNI database is a very good database and it's good to have, but it's also not really a benchmark data set as you have in computer vision, where you also directly define what is the training data, what is the test data. So all the approaches, so all the analysis you're going to compare, which have been applied on ETNI, are not comparable because everyone used different data, different approaches, different pre-processing and whatsoever. And there's one recent study where people try to benchmark this and also classified all the study depending if there might have been a data leakage or not. So of course they can't truthfully tell if there was a data leakage, but they could exclude some studies where have not been a data leakage, and they could tell if where could be a data leakage. And therefore, because for the ETNI data, you have, for example, the data of different time points, and it's very important to don't mix up those different time points between training and test data, then you would have the same. Yeah.
I think there are so many more points that at least I have in my mind to discuss. Maybe, Kerstin, we can follow up on another meeting and
yeah, sure. Definitely. I would like. Really, yeah, really very interested in your perspective.
Also, there are lots of opportunities for collaborating with neuroradiology. If we know what you would be interested in, it would be relatively easy to also, you know, set some data aside on one hand, but also on the machine learning part. And I was particularly interested in your knowledge in transfer learning and making the deep nets explainable or at least interpretable. And I would like to give Timon the chance to ask his question, he is working mainly in the machine learning part with our data.
Yeah, for me also a very nice talk. I have a general question, especially to transfer learning. You probably know the ResNet approach that just used image classification data with a really well trained net that is also more than 100 layers deep. How did that work in regard to fMRI data? Because for your transfer learning approach, you used a different data set that also used fMRI data, right?
Yeah, so we mostly use structural MRI data here, so not functional MRI data. Functional MRI data is more difficult because then you also have the time domain, and there are also like different approaches, but structure minded. Yeah, and we also mostly analyze those data in 3D and not 2D. So the problem with those pre-trained networks are mostly on two-dimensional, like ImageNet, for example. At the moment, we have a project where someone is using a ResNet, but not a very deep one. And this was also pre-trained on the ImageNet. And this works also fine on this data we have here. So we are synthesizing some data for this. And there are also studies that have shown that also networks pre-trained on ImageNet can work quite well on MRI data, but that you can also pre-train an MRI data. But this is exactly something which is not investigated till the end. What is the best approach to transfer learning? And I can just tell you what works for us. And since we wanted to have those 3D CNNs, it's difficult to have a pre-trained network on something else. And we therefore pre-trained on the Alzheimer database, and we used a different sequence and a different task. So this was so we had MPRH data. So we transferred from MPRH to FLAIR data and from Alzheimer's disease to multiple sclerosis. And this worked relatively well. What we also tried is to using unsupervised learning, like training autoencoders, because this is such a nice idea to just train on healthy controls, and then you know what is important for a healthy brain, how this looks like, have a representation, and then you can define everything else as a deviation from this. So this is a very appealing idea, and we several times trained autoencoders, but it did not work. So we get a good reconstruction, but we did not learn anything useful. And therefore we found it's better to have another supervised learning task, even if it's different data, and then use this as an initialization for our network. But yeah, this is something we much more need to address. So what would be do you have a specific project in mind where you want to transfer from ResNet?
Yeah, I think we have to wrap up, unfortunately. But as I said, we will follow up with that, and I think also Timon and you can have hours-long discussion about these things.